So the title of my talk today is Iron, Friend or Foe. And really, I'm going to really focus on iron overload and cellular aging. So there is a big paradox about iron. We know collectively that iron is good for us, but iron also can be evil. Iron is essential for life. We need iron to carry oxygen and to carry blood throughout the body. Without iron, we can't live. Not only is iron important for life and the delivery of oxygen, it's also important in many, many different enzymatic reactions, especially related to DNA production, ATP production, really important for mitochondrial health. So overall, we know that iron is good. It's good for our bones, muscle, brain, nervous system, and hormones. Iron is good. And we know about the Popeye effect, right? Who ever watched Popeyes growing up, right? Popeye eats some spinach, it gets some iron, gets good muscles, and then he can rescue olive oil, his beloved olive oil. So in our mind, iron is good. It is, but here's the paradox. Iron is also a toxin, and it is one of the most important toxins that you've never heard about. And the way iron can be a toxin, it is because it can give an electron and it catalyzes the production of reactive oxygen species. That's a big word, ROS. ROS is the oxidant that can destroy every part of our cell, starting with the membrane, the lipid membrane of the cell, the protein structure, and even the nucleic acids and the DNA. So iron is a toxin. When I started learning about this, it was mind-blowing, because in my mind, iron was just good for us. The more muscles, the better it is. And this is how iron is a toxin. It's by the formation of oxyradicals. Oxyradicals are, for example, on this one, it's OH minus, and that's called the Fenton reaction. It's one of the most important reactions that we've never heard about. When iron mixes with H2O2, hydrogen peroxide, and other different molecules, it causes the formation of hydroxyl radicals that are the most damaging to any cellular part of our body. And easy to say, when I say oxidation, reactive oxidation species, those are big words. Just think like this. Oxidation is a fancy term for rust. Think about your chair that you left outside and it's rusting. This is what iron is doing to our cells. So now let me go back a little bit and talk about the physiology of iron. How do we get iron into our body? So there's 3 different forms that we can take iron. Heme iron, that comes mostly from meat, seafood, poultry, and it's one of the most absorbable forms of iron. There's also non-heme iron that comes from plant food, legumes, lentils, less absorbable. Spinach is not the best way to getting iron, but it is part of it. And then there's the inorganic form of iron. This is what these fortified our foods with. They put basically filings of iron into most of the flour and the grains in our country. And this is very absorbable. So here's a complicated slide on the physiology of iron. So very simply, the way we get iron is, let's see, whatever. So iron comes in, we take iron in, goes into intestines, gets into the enterocytes, which is the cells of the intestine, goes into the bloodstream, and gets distributed to all the different organs. One of the main organs is the liver. Previous lecturer spoke a lot about the liver, and it's amazing. One of the most important organs, and iron both gets stored in this, but can be toxic to the liver. It also goes to all different tissues, and also to the bone marrow, so it can make blood. One of the most important actions of iron. Something that's really important, and I didn't know about this before doing this lecture, 98% of the iron that we use in our body comes from recycling of the old dying red cells in our body through the spleen and the macrophages, and it's called the reticular endothelial system, the RES. 98%. So from our diet, we only need to get 2% of the iron from our diet. So iron is so important. There's been multiple cellular mechanisms that have evolved to regulate it because it is such an important element. And this is one of the most important slides. It's kind of complicated, but I'm going to run you through it. Who's ever heard about hepcidin? I only found out about this 6 months ago. Hepcidin is the main regulator of iron and the most important molecule we need to know about. Hepcidin is basically the gatekeeper of iron intake. So like before, the way we get iron is it gets absorbed through our intestine or gets recycled through the spleen. Hepcidin controls all of this. When you have normal iron stores or high iron stores, hepcidin levels are high, and it blocks the absorption of iron, blocks the release of iron from the spleen. When our iron stores are low, hepcidin production is low, and it encourages absorption of iron. Really important, remember that word, hepcidin, controls the gatekeeper of iron. And this also was mind-boggling to me. How much iron do we need to take from our diet? Remember I said only 2% needs to come from our diet. The RDA, the recommended dietary allowance for iron for men and postmenopausal women, it's 8 milligrams a day. And I'm going to say that and I'll say it again. Centrum vitamins has 18 milligrams of iron. One vitamin, you have more than your RDA. For pregnant women, women of menstruating age, and children, they need more iron. But for a postmenopausal woman and a man, 8 milligrams of iron is all you need. And look at the common iron content of certain foods. As you'll see here, the protein, the cereal, and the bread, all those are fortified with iron. So they have a high iron content. Even meat that we think has a high iron content, it's about 2 to 3 milligrams of iron per about 4 ounces. So just think about you having your protein bar, you have some healthy cereal in the morning, a slice of bread. Look how much iron you're getting. And here's another kicker. There is no physiological way to excrete iron once it is absorbed. It is the only element that's like this. You cannot sweat iron out, you cannot poop iron out, you cannot pee iron out, and you cannot lymphatic drainage iron out of your system. Once it's in, it stays in. The only way to get rid of iron is to lose blood. That's why women are protected from iron overload when they are menstruating. Once they stop menstruating, they have the same risk. So really important concept. You can't sweat it, pee it, poo it out. So this is why we get iron overload. It's a bioaccumulative toxin that cannot be excreted. And it causes oxidative stress, which we all know now. It's rusting. So it is a biological fact that we will all experience iron overload, no matter where we live, no matter who we are. Because as it accumulates, you can't excrete it. It will eventually accumulate in the body and go into your different peripheral tissues. It is a biological fact. So what are the different ways that we can get iron overload? 3 ways. Number 1 would be the excess dietary iron, and we'll talk about this. Number 2 would be a genetic disease, very common. And number 3, other factors. On number 1 of the dietary iron, like I was saying, the standard American diet provides way much iron than what we need. On average, it's about 20 milligrams a day. Remember I said 8 milligrams a day is the RDA. And for men and eating a lot of meat, carnivore, if you're cooking out of an iron cast skillet, some people get 60, 80, up to 100 milligrams of iron. What's important to know is that in this country and many European countries in 1941, they started fortifying all of our foods with inorganic iron, iron filings. And they did this because of a good reason. Back in the 1920s and 30s, there was a lot of iron deficiency anemia. Nutrition was poor. So women of childbearing age, kids, they tend to suffer from low iron. So in their infinite wisdom, the FDA decided to add iron to all of our foods, no matter what your needs are. Despite doing this, that was back in 1941, there are still a lot of women and children who suffer from iron deficiency anemia. So it didn't really fix it, but what it did, it exposed everybody else to excess levels of iron. So that was done in 1941. Then in 1960, the FDA said, like, it's not enough. Let's add more iron. So every time you're eating some kind of grain, including flour, crackers, cereals, they're fortified with iron. Actually, the country of Sweden did the same thing. And in the 1990s, they stopped that program because they realized we may be helping a small proportion of our population, but we're poisoning the rest. And here's an important concept. Genetic diseases as a cause of iron overload. Hemochromatosis. So hemochromatosis, when I went to medical school 30 plus years ago, I'm not even going to say that anymore, they told us it was a rare disease. My hematologist friend would tell me, you'll maybe see one or two in your career. This is so far from the truth. So hemochromatosis is a disease of iron overload where your body accumulates iron and keep absorbing iron despite your iron stores being high. It affects about 10% of the Northern European ancestry. So it's a genetic mutation that originated in Northern Europe, and it was actually an evolutionary benefit to have this. Because if 10,000 years ago, you were living in a low iron environment and you're in a battle, you get caught, if you have a predisposition to retain iron, you would be most likely to survive. So that was able to be passed on to genes. So now, when you look at the population in the US, 1 in 10 can be heterozygous, meaning having one mutation for the hemochromatosis gene. About 0.5% of the population will have this. In a place like Ireland and the UK, it can be up to 20% of heterozygous. It's pretty scary. I started checking genetics, genomics on a lot of my patients, and patients who have hemochromatosis gene, whether you have 1 or 2, you're at high risk of having iron overload. If you live in this country and you eat carbs and you have a predisposition to retain iron, now you understand when the speaker before me was saying how important liver health is. Well, this is one of the bases of cellular physiology. If you accumulate iron, first place it usually goes to, it's in your liver to cause fatty liver. So hemochromatosis is very important. And I recommend anybody who has any kind of Northern European ancestry to check their genomics. And it is not just Northern Europeans. It is, can be affected by almost every population. Besides so the genetic variant comes usually from the HFE gene. There's also non-HFE variant. Mind you, the HFE variant was only discovered in the 1990s. They've known about hemochromatosis since the 1800s. And it was a combination that we learned in medical school. Usually hemochromatosis had a triad: bronze skin, diabetes, and cirrhosis. That used to be in all of our medical boards because it was a rare disease. The bronze skin from the accumulation of the iron, it goes to your liver, causes cirrhosis, and the accumulation goes to your pancreas, diabetes. I remember that board question, and it was a rare disease. Not based on this. Once they found the genetic cause, they saw that it's more common. And besides the HFE variant, we're finding out more. There's non-HFE variant. There's 4 different that we found out. Maybe in 10 years, we'll find another 10. So progress is showing us more how dangerous iron overload can be. And other factors that can cause iron overload. Just the fact of aging, we tend to accumulate it more. Our bodies, our hepcidin is less stringent, so we tend to accumulate more. Obesity, insulin resistance, that's a big one. And we have an epidemic of obesity and insulin resistance. And it causes also elevated iron levels. Drinking alcohol. We all know that drinking alcohol is bad for our liver, but one of the ways that alcohol affects our liver is that it decreases hepcidin. Remember that molecule, hepcidin. When it decreases hepcidin, your body keeps absorbing iron even when you have normal or high stores. So alcohol is toxic double to your liver. It's directly toxic to your liver cells, and it increases iron absorption. And another thing that I found out, which was mind-boggling to me, because I'm a functional medicine specialist, a men's health specialist, and I prescribe a lot of testosterone and growth hormone for my patients. And my patients do well. So here I am congratulating myself, helping patients deal with their low testosterone issues. But look at this. Testosterone and growth hormone also can decrease hepcidin and cause increased absorption of iron. This was found out on a paper in 2018. This is new information. I've been in this field for 15 years. I never knew about this. I go to all longevity conferences. We never talk about iron. We talk about testosterone. We talk about growth hormone. We talk about mTOR. Iron is one of the most important things that we don't talk enough about. Look at all the diseases that can be associated with iron overload. It's almost every disease of old age, every chronic illness can be associated with iron overload. It's crazy. Everything from pituitary disease, including low testosterone, hypogonadism, infertility, ED, iron overload that is directly toxic to the pineal cells, can cause ED, chronic fatigue, cancer, neurodegenerative diseases, Parkinson's disease, multiple sclerosis, Alzheimer's disease, autoimmune disease. It's everything. The main complaint that somebody with iron overload would have usually includes three. Number one would be chronic fatigue of unexplained origin. Number two would be brain fog. Number three, and we have my rheumatology friend over here, joint pains. And there's a specific joint pains where you have the first two, it's called the iron pointers. Those two joints get swollen and inflamed. It's pretty specific for iron overload. Non-traumatic ankle pain, ankle arthritis, check iron. Again, how can one element be linked to so many diseases? Let's go back to cellular physiology. Because iron overload rusts our cells, oxidizes our cells, oxidizes our mitochondria. It can affect every organ system of the body. This is basic cellular physiology that they didn't teach me in med school. I did not realize in functional medicine how important this is. We need to go back to the basics, and this is the true root cause of so many of the diseases we're seeing. What iron does to metals outside, it does it to our cells on the inside. It rusts our cells. Read that again and visualize your poor little cells being rusted. This is what's happening. And I love this quote. Iron rusts everything, and rust never sleeps. Actually, rust never sleeps. This is a song by Neil Young. He knew it. Rust never sleeps. Let me give you a few examples of diseases associated with iron overload. Number one would be liver disease, like the lecturer before me was talking about. Iron tends to go to the liver first. That's where it is being stored. So iron is very closely associated with fatty liver disease that can then progress to fibrosis and then progress to liver cirrhosis, which now becomes, you can't reverse liver cirrhosis and even liver cancer. Iron can go also to the pancreas and cause insulin resistance and diabetes. And there's a bidirectional relationship with insulin resistance and iron. Insulin resistance causes iron overload. Iron overload causes insulin resistance. There's a loop that happens there. And this is a beautiful picture. So usually when you do a biopsy or an MRI, they usually stain it with Prussian blue. So you will see that the Kupffer cells of the liver will be blue, full of iron. Beautiful blue, very toxic blue. Iron and heart disease. My friend the cardiologist right here. This is one link that we tend to forget about. How iron is one of the most toxic substances to the heart. And it can be directly cytotoxic to the heart cells. There's an iron heart hypothesis that shows that most heart disease can be caused by iron. And when we think about cholesterol, right, there's a lot of controversy. Is high cholesterol the cause of heart disease? If you do a fractionated lipid profile and you really look at the different molecules, what we look for is something called oxidized LDL. Oxidized LDL is what actually causes most of the dangerous plaque. And what is oxidation? Rusting. So rusting LDL, rusted LDL is the problem, not just LDL. So iron in combination with cholesterol is toxic to the heart. Also, iron can cause decrease of muscle function associated with cardiomyopathy, low heart function, heart failure. Also, iron is very toxic to the sinoatrial node, where it can cause arrhythmias. So a lot of patients with iron overload will complain of palpitations. Check iron with any of those symptoms. Also, iron is a carcinogen. Iron is one of the only elements that is implicated in all three phases of cancer formation. It can initiate cancer, promote, and progression of the cells. Most toxins, I'm going to take an example, plasticizer, which I'm talking about tomorrow, BPA, phthalates, they initiate cancer formation, but they have nothing to do with cancer promotion or progression. Iron is in all three because cancer cells need iron to grow. So it's been associated very closely to colorectal cancer, to almost every cancer: colon, lung, liver, breast, and scrotal cancer. This is another tough one that I did not know about. Iron in the male reproductive system. The pituitary has been found to be particularly sensitive to iron overload, and especially the anterior pituitary, the gonadotrophs that secrete LH, luteinizing hormone, and FSH, that are responsible for the production of testosterone, estrogen, and progesterone. And they've done autopsy studies, and they've looked at, in the general population, those are not patients with hemochromatosis, that starting at the age of 30, that iron starts accumulating in the pituitary and eventually can cause fibrosis. How crazy is this? So we start accumulating iron, and this is one of the theories of aging, is that iron, as we get older, starts accumulating in the peripheral tissues, including the pituitary, causes a lot of a decrease in hormones. So, and here's another kicker. Iron overload accumulates in the pituitary and is a very common cause of low testosterone, secondary hypogonadism. So I look at my practice. I started seeing a lot, since I started checking iron on my patients, a lot of my younger patients that I'm seeing come in with secondary hypogonadism, meaning you have low testosterone because your pituitary doesn't send the messages to your testicular cells to make testosterone. A lot of them, I found high iron. If you help them donate blood, some of them can reverse that. For some, eventually, once it accumulates in the pituitary, it can cause fibrosis of the pituitary, and it's now irreversible. So by the time I see a lot of them, it's already irreversible. So I treat them by giving them testosterone, which is the right thing to do. But lo and behold, testosterone therapy can decrease hepcidin. You remember hepcidin? That's the gatekeeper of iron. It can decrease hepcidin and cause increased absorption of iron. So everybody who's on testosterone now, they need to know that when you take testosterone, it causes physiological hemochromatosis. Hear that again. Not hereditary hemochromatosis. So it has the same mechanism of action of hereditary hemochromatosis. Testosterone decreases hepcidin. So as a testosterone-taking guy, I'm on testosterone. And I realized that my iron levels were kept increasing. I've been on testosterone for 7 years, and I look at my labs over the past 7 years, I've seen that my ferritin has steadily climbed. I don't have the gene for hemochromatosis. What's causing this? Testosterone decreases hepcidin. So in theory, I have now physiological hemochromatosis. So I need to know this, and I need to deal with this. And my goal is to bring that to everybody who's considering biohacking, everybody who's taking testosterone, because now LOTI has become an epidemic, both for men and women. So testosterone is a good thing, but you need to be aware of that relationship. I have to talk about iron deficiency anemia. Although this talk is mostly about the dangers of iron overload, iron deficiency anemia is real and it affects a lot of people. Women of menstruating age with heavy period, children, they need iron from their mom. If they live in an environment that there's not enough iron, it can be associated with so many different conditions. So iron deficiency anemia is very important. I'm not trying to diminish that fact. Today it's more about iron overload. But low iron also has been linked to many health problems: fatigue, increased heart rate, shortness of breath, anxiety, depression, sleep disorders, brain fog, low IQ, poor circulation. So iron deficiency anemia is dangerous and it needs to be corrected. So this is a whole other talk, but I wanted to mention this. So how do you check your iron status, right? So this is all the theory that we checked about. What do you do to check your iron status? And this is what I like with this. It's very easy and very cheap to check your iron status. And it doesn't matter if you go and see your doctor and you do your yearly physical. This is not usually checked. We only check, again, I'm a conventionally trained medical doctor also. And in my yearly physical exam, when I worked at a primary care physician, I never checked that. Unless it was a woman that I suspected iron deficiency anemia, I would order those labs. But in general, we don't. Now this is part of my routine blood test. We need to check that at all times. And it's very simple. You check your total iron, you check your TIBC, which stands for total iron binding capacity, your transferrin or iron saturation, your ferritin, which is one of the most important markers, hemoglobin, and then if necessary, the genetic testing for hemochromatosis. Those are very easy to get those. LabCorp, Quest, our company, we do it. I recommend everybody make sure, take a picture of this and make sure that you get your doctor to check those levels every year for you. The word of caution: ferritin, one of the most important ones, is not a perfect measure. It is an acute phase reactant, meaning that it increases if you have an acute or chronic infection, autoimmune disease, cancer. So sometimes you'll see a patient with high ferritin and you will think, oh, he has high iron. Could be insulin resistance. It could be autoimmune disease. Any of those things can cause a high level of ferritin. Also, the iron saturation, which for hemochromatosis is calculated as iron saturation 45% or more. But it varies a lot day to day and patient to patient. If you had a heavy iron meal before checking it, you can have a falsely elevated iron saturation. So the way I usually do in my practice is I check those levels, and if they're high, I make sure that I repeat it to confirm it and make sure that the ferritin is not high because of another reason, like insulin resistance, infection, autoimmune disease. And very important, although the blood iron levels are important, it's been shown that it can underestimate the tissue iron, which is the important one, by 10x. 10x. So blood iron levels are important, but they are not the end all of your iron status. The gold standard to determine iron status used to be biopsy, invasive. Now, thanks to progress, they have an MRI, but it's a specific MRI that checks for your liver iron concentration, LIC. In the Miami area, I called almost 10 MRI centers. I only found one that can do this. But if you have high iron and you're not sure about what your blood test is showing, this is important to check your liver iron. And there's an algorithm that can give you your total iron concentration. Really important to do. Everyone should know their iron status. Whether you're a man, postmenopausal woman, have Northern European ancestry, whether you have heavy period, women with heavy period, basically everyone should know their iron status. Why? Let's go back to what I've been talking about. Iron is a toxin. It's bioaccumulative. You cannot excrete it. It causes oxidative stress to the cells in our mitochondria. Oxidative is rust. It's rusting our cells in our mitochondria, and it's been associated with almost every disease of old age. Wouldn't you want to know your status? I checked mine, and I was high. I want all of you guys to today ask to know your iron status. This is a powerful statement, and that wasn't said by me. This is Jim Moon, who wrote a book, Iron, the Most Toxic Metal. He has 20 plus years of experience as a biological toxicologist, and he also has a master in nutrition. And look at this sentence. Iron excess is responsible for more sickness and death in North America than any other single factor, including cigarette smoking. That is a powerful statement that is said by a very experienced toxicologist. I saw that and I gasped. How did I never hear about this? And here's an important study. So it's a busy slide, and I'm going to try to go with it with you. Because you can have all the theory you want to see in real life. Are there studies that can point you to a direction? So this is a study that was done in Scandinavia, in Copenhagen. So it's called the Copenhagen Heart Study. It's almost the equivalent of the Framingham Heart Study in the US. So they followed about 10,000 patients, 10,000 people for 23 years. And they looked if there was one factor that could really correlate with longevity. Interesting study. And they found that stepwise increasing concentration of ferritin were associated with stepwise increased risk of premature death. Here are the results. There were no other single factors that could correlate with longevity. Not blood pressure, not cholesterol, nothing. Just ferritin on that study. And they showed that the higher your ferritin level, the younger you will die. Ferritin level above 600, median survival 55 years of age. Median ferritin between 400 and 599, 72 years. Less than 200, 79 years. So you see there's a difference of 24 years between the highest level of ferritin to the lowest level. No other biomarker has been shown to have such a linear correlation with longevity. None. That was mind-boggling to me. I've been in the longevity business for 15 plus years. I'm just learning that. We're going back to the basic. So wouldn't you want to know your ferritin level? Isn't that important, right? And what's important there, the ferritin, they did not determine whether the patient had iron overload. Even if you have high ferritin for an autoimmune disease, from a chronic infection, high ferritin was correlated with survival. High ferritin can be correlated with poor liver health. That's what it shows. But the ferritin, it's easy to measure, easy to follow, and easy to correct. So now, you check your labs. You're like, doc, you convinced me. I need to check my iron. Iron is bad. We need it, but iron is bad. What do we do? I found that my iron is high. What do I do? And there's usually four things that we can do about it. And the number one and most important one is blood donation. Blood donation is the most effective way at removing iron from our body. And if we think about it, in our medical history, we've used some kind of bloodletting for hundreds of years. In the 1800s, we were using leeches. Actually, in France, they had hospitals dedicated to the use of leeches. You put leeches on you, it sucks the blood out, and you get treatment. People had beautiful decorated urns where they kept their leeches. There's a French aristocrat that his life was saved by 2 leeches that completely drained his blood and helped him get better, and he gave them a name. Those were his pets. Besides leeches, we used to do venesection. In the Middle Ages, the way a doctor would treat you, they just come in, they cut your vein, and they let you bleed out. They were talking about bad humor, bad blood, sour blood, toxins, and iron they were getting rid of. So blood donation is really, really important. And as a rule of thumb, when you donate about 1 unit of blood, you decrease your ferritin by about 30 to 50. So if you were to find that your ferritin is 600, for whatever reason, you see the number of blood donations you need to get before you get to that level 200 and less than 100. And different studies, and I put the source here, the optimal ferritin levels for men and women. Optimal ferritin level for men, less than 100, between 50 and 70. And for women, between 20 and 40. And that's important to know, because when it comes to iron, too low is also dangerous. The lower is not always the better way of doing it. So it's a very tight window. So for example, men, I see that a lot in my practice. Guys who are on testosterone and donate a lot of blood, and they will drop their ferritin below 20. Most of those are symptomatic. They have brain fog, they are tired. They think it's because they need more testosterone. It's because they were over-donating blood. Women who bleed too much, who have a heavy period, when their ferritin get into the teens, they will tell you this. They don't feel good. So there is, like everything in life, iron needs to be balanced. Low iron is bad, high iron is bad. So you want to aim for those levels. And lower levels of ferritin through phlebotomy have been associated with lower risk of diabetes, heart disease, and cancer. And I have the citation here from the study that frequent blood donors live a longer life in average than non-blood donors. I became a blood donor again. My wife is a blood donor again, and I recommend and encourage all my guys here are going to be all blood donors because of this. Other thing we can do if we find that we have high iron, very important, iron chelators, and there's different ones. There are prescription iron chelators. I don't use those tend to have more problems, so I have a few hemochromatosis patients that I will actually send to my hematologist friends, and they'll do a combination of iron donation, blood donation, and the prescription chelators, things like X-Jade. There used to be only IV, now there's an oral form. But besides this, there's non-prescription iron chelators that are really important. And things like quercetin, curcumin, green tea, black tea, all of those, resveratrol, drinking wine with your meals, all of those usually bind iron and prevent the absorption. Also, there's IP6, inositol hexaphosphate 6. It's a natural iron chelator that you find a lot in legumes and things like lentils. Really important. So you want to, if you are found to have high iron, you want to donate blood, but you also want to take antioxidants. What is antioxidants? Anti-rust, right? Iron rust oxidizes. You want anti-rust, antioxidants. Things like glutathione, very important. Berberine, silymarin, that has milk thistle. So taking all of those, whether you get that from your diet, from supplements, really, really important. And of course, if you have high iron, being aware, where are you getting your iron from? Trying to eat a low iron diet. And as you see on the previous slides, where we get most of our iron in this country, it's not even from meat. It is from the carbs that have been fortified by those filings of iron, inorganic iron that is readily absorbable. So learning about a low iron diet, for example, the Mediterranean diet that has all those benefits is a low iron diet. So learning this is also very important. So you remember my question in the beginning? I told you I was going to tell you about a biohack that was proven to increase longevity, that was free, and that the world needed. Iron management is that biohack. It is the most important, the most basic biohack for health optimization and longevity. And I'm going to call out my wife here, as she is postmenopausal, take testosterone. We never checked her ferritin before because she used to have low ferritin when she was menstruating. And we found her ferritin to be elevated, 158. For women, up to 150. 158. So she has multiple reasons to have iron overload. So we started donating blood. And she went to this company called One Blood and she donated blood. And look at the email that she received. And I have to read that for you. It said, "Dear Keisha, your whole blood donation was a perfect match for a patient in need and was sent to Johns Hopkins All Children's Hospital. Thank you for giving the gift of life." How beautiful is this? Not only is she doing something that's healthy for her, she's helping a child to have life. So this is a biohack that not only helps you, it helps the world. How amazing is this? So this is my Dr. Rudy euphemism. Donate blood, save a life. Dump iron, save your life. Thank you, everybody. Thank you, thank you. Questions? Very good. Yeah, $59 at Quest. When you go, something that's very interesting, sometimes you will go to One Blood or the Red Cross, and they will check your iron, they say. And they'll be like, you have high iron or low iron. They don't really check your iron, they check your hemoglobin. Usually, you need to have a hemoglobin above 13 for women to be able to donate, and for men about 15. So they will tell some patients, be like, they check my iron at the Red Cross. It's not iron. They check your hemoglobin. Everybody should know their iron status and check all of those. It's pretty cheap at Quest. Things like any lab can do it. Our company does it. It's pretty cheap. And I recommend everybody, the same way you check all of your cholesterol yearly, you need to check your iron yearly. Really important. Questions? Mm-hmm. To do. So let me say the question, and it's a great question. So Dr. Ellie is a cardiologist, good friend of mine. So what he's asking is, so it's when they did the study, it's not a one time, they followed stepwise levels of ferritin. What do you do with somebody who goes and check their labs, ferritin is elevated, should they panic? What do you do? How do you distinguish it, iron overload versus something else, right? So number one is, yes, so a one-time ferritin level doesn't tell us much. First, we don't know how long you've had it. So that's why it's important to check it regularly so we can track it. So that study, it was a observational meta-analysis long-term study. And they've seen over 20 years, the people who've had high levels had those bad outcomes. So one time, it doesn't tell you much, but it just tells you what you should do now. And to answer the second part of your question, when you have a high ferritin level, is it iron overload? Is it insulin resistance? Is it lupus? Is it rheumatoid arthritis? Is it because you're drinking too much and it causes that? All of those things can cause a high ferritin. But in that study, no matter what the reason for the high ferritin, it was associated with a lower survival range. So when I see a patient with high ferritin, I put my detective hat. Why do you have a high ferritin? Is it because you have an autoimmune disease, a chronic infection? Is it because you have insulin resistance? Or patients, if you have visceral fat. So we'll put them on a low iron, anti-inflammatory diet, and we'll monitor it. A lot of my patients, when the ferritin is kind of mildly elevated, 400 to 600, just really decreasing their diet and really helping them with lower insulin resistance, less visceral fat, belly fat, will decrease their ferritin. And you want to look at ferritin in association with the iron saturation. If you have a high iron saturation for hemochromatosis, it's 45% or more. If you have 45% or more with a high ferritin, you start thinking more, could it be hemochromatosis? That's when I want to do the genetic testing and really look into it. A lot of the hemochromatosis patients, their ferritin will be in the 1,000. I diagnosed a patient, his ferritin was 3,500. This guy, I had to send him to the hematologist because he was getting blood donation every week until his ferritin got down to the 200. Now he does maybe blood donation maybe 3 times a year. But it took him almost 6 months of weekly blood donation. And in your mind, you're going to think, wow, this guy's going to get weak. He had so much iron reserve that it took him that long to drop his ferritin. Yeah. Second question? Yeah, so great question. Anything in the pipeline to increase hepcidin to decrease the absorption of iron? I haven't seen anything, and hepcidin, again, was only discovered 20, 25 years ago. They're actually going to have, you can check hepcidin only in research lab, but it's going to be a new thing they're going to have soon. And for example, if you have a high hepcidin level, if you have a low hepcidin level, it's a precursor to knowing you have iron deficiency anemia. So it's going to really increase our diagnostic yield. For now, it's not available yet to check at Quest or LabCorp, and there's no therapeutic that I know of yet for this. Question? Say that again? The different types of dietary iron. So you're saying, so cooking in a cast iron skillet can increase your iron intake, right? Yes, it can. So that's a big question because, we don't know what to do anymore. I have a talk on endocrine disrupting chemicals and toxins tomorrow on the main stage where we talk about all the PFAS, the plasticizers, mostly PFAS that we find in non-stick pens. Non-stick pens, we've all used them. Who've used a non-stick pen? Almost all of us, right? So we had to stop doing it. When we stopped doing our non-stick pens, our kids at our house hated us because it was burning everything. Non-stick pens are easy to use, but you get all the toxins from it. So we went into cast iron skillet. It's kind of hard to use. You need to season it, but we got it. So can we get extra iron by using a cast iron? Yes, you can. It tends to be not that much, so the benefits tend to outweigh the risk. And one thing they said, for example, if you're going to do a steak and you're going to sear the steak on a cast iron skillet, don't use citrus type fruits marinade. You use sour oranges, my Cubans out here. If you use lemon juice, the vitamin C increases the absorption of the iron. So you get even more from the cast iron skillet. So yes, you can get more iron from a cast iron skillet. If you have normal irons, it's usually okay to use it because it's not that much you get from it. But a normal pen? What do you mean by? Yes. So if you have normal iron panels, it's okay to use it because it's really not that much that you get. Say, huh? The coating pen? What do you mean by coated? Coated with? So the coating, most of the time, that's why they use PFAS, chemicals. So the coating that we usually do, because we got an iron cast, and it took us forever. The coating, it has to be with the spices. So you don't wash it with water, the cast iron. And you let a coating of organic material form, and you can cook better with it. If there's coating, Yes. Good question, because the cast iron skillet is great, and that's what they've used all the time. We can still use it, but you got to be aware of your levels and manage it. So thank you. Other questions? All right. So thank you so much, everybody. I hope you got something out of this. Thank you.